Yeah, I'm going to talk to you today about how to use modelling and simulation to help develop safe medicines in patients. So just a brief background about myself, because I'm sure I haven't met many of you before. I started out by doing biochemistry at Sheffield, and then I joined AstraZeneca in 2003. I joined the Discovery DMPK department, so drug metabolism and pharmacokinetics. So here it's where we study what the body does to the drug. So, you know, the fate of the drug once it enters the body and how it's absorbed, etc. And I did that for several years supporting diabetes projects. I had a keen interest in modelling and simulation, and I was lucky enough to get a secondment over to Gothenburg in Sweden to join AZ over there to focus on PK/PD modelling, and that was with arrhythmia projects. So that was my first real taste of kind of cardiovascular safety. And when I returned back to the UK, and I started studying for a master's in modelling and simulation with Manchester at that time, and I kind of did that alongside my role. And then eventually I moved into safety pharmacology, where I guess there's a lot of focus on kind of QT, prolongation, and those kind of risks. And then a kind of bespoke safety modelling team was formed during reorganisations. And up until that point, in the UK, I'd been based in Cheshire. And then in about 2015, I moved down to Cambridge, which is where we're based now. All the research is based down there. And now I worked in that team for several years. And then I was fortunate enough for the last 2 years, I've actually led that safety modelling team. And then more recently, I've now moved on to clinical pharmacology. So I've just started a new role there. And that really comes from wanting to get more clinical experience. A lot of what I've done previously has been kind of first time in man and the development of the candidate drugs, whereas now I want to learn a bit more about what actually happens when you develop, you know, clinical development and how that works. Okay, so my interest is mainly around cardiovascular safety, how to help projects build understanding of what that risk will translate to in the clinic. I'm also interested in bone marrow toxicity or hematopoietic toxicity, and done a lot of work in that space as well. Also, I'm always thinking about so primary pharmacology is very important. But during my time in safety, I've realised how important secondary pharmacology is as well. So that's when you've got kind of unwanted pharmacology at different targets. And sometimes that's like selectivity, or sometimes it's just crop up and you have no idea what's causing it. So I'm always looking to find ways to give confident and quantitative clinical translation for pharmacology. And this can border into toxicology as well. And then finally, my role has always been to kind of branch out in terms of what are the modelling needs. So my background is mainly small molecules, but there is so much more to our drug portfolio in AstraZeneca. I mean, we're doing some really interesting therapies these days, including things like ADCs, antibody drug conjugates, cell therapy, things like CAR-T therapy, and then also things like antisense oligonucleotides. And these all have different kind of safety profiles. So how do we manage that and support that as well? Okay, so just moving on now to cardiovascular safety. I'll focus my talk today. We kind of in AstraZeneca think about 3 broad categories of cardiovascular risk. There's changes in electrophysiology, which I'm sure you're all aware of. Things like ion channel inhibition leading to changes in ECG, such as QT prolongation, leading to potential for arrhythmia, and rare events leading to death. We also see a lot of compounds coming through the pipeline that have hemodynamic effects, and I'll show you an example that later. So that's where we're thinking about, you know, the regulation of the blood pressure and heart rate within the body. And then, of course, we're working in the toxicology space, so we always have a concern that drugs could be causing pathological damage, so irreversible structural damage to the myocardium and the vasculature. And so these are the things that we tend to focus on, but it doesn't come without its challenges. Now, when we're looking at, we may have a very strong understanding of what's happening in vitro, and we may be able to have a kind of molecular assay that, you know, with an overexpression system with a particular ion channel, and we can understand the level of inhibition for different concentrations, but then we've got to scale that up. So the challenge is always how to cross these scales. So you start in, you know, at the molecular level, what happens at the cellular level, and then what happens, you know, at the tissue, and what you're actually monitoring in vivo or clinically, and then how that's going to influence population effects. So this is really, you know, the difficulties that we face is that often, you know, the quantitative link between these different scales, these different, you know, both distances and timing wise, how do we cross these in a good way? And you really need modelling and simulation for that. Okay, so I just want to briefly talk about the types of modelling that we do within industry. So we can modelling and simulation package, and I can't say that, you know, we work in one particular area. My work has mainly focused in the PK/PD area, so that's where we're linking pharmacokinetics to pharmacodynamics, so the effects that the drug is having in the system, and trying to link those two things together. But that can obviously be quite descriptive modelling, and it can be predictive in some sense and in some settings, but it can't give you that real understanding of the biological impact. So for that, you're going to need something like systems biology, which kind of captures the biology as well as the mechanism by which the drug is having an effect. And it's much more detailed and much more detailed, and it can span those scales a little bit better. In terms of pharmacometrics, this is kind of the more statistical PK/PD approach that we have in clinical development, and this is something that I'm hoping to learn more in my new role. So, you know, thinking about these different types of modelling that we can do, one thing I'd like to mention is systems pharmacology, or systems toxicology that we call it, and this is where we're kind of trying to do a bit of a hybrid between the systems biology and the more PK/PD focused approach. So normally with PK/PD you might only look at one or two different endpoints, and they're all linked back to the pharmacokinetics. What we try to do with the systems pharmacology is kind of link the system in a more biological way. It's still going to be a gross simplification of the system as a whole, but it kind of takes into account kind of the key processes between variables. So just thinking about, you know, what I've got on the right here, you've got the pharmacokinetics driving a change in heart rate and blood pressure, but these also have an impact on one another. Blood pressure has a kind of feedback loop on the heart rate, and I'll go through this a bit more later, but it captures some of the physiological processes. So this is the kind of area that we're trying to build more models in these days. Okay, so I'm just going to take you through kind of three different areas today. So the predictivity of ion channel effects, hypertension risk associated with FR2, and then hemodynamic models. Okay, so because in industry we're sat on a kind of large repository of data, we've taken many compounds into the clinic. We already have a really good historical knowledge of how compounds will perform. So if you imagine, AstraZeneca has maybe 30 plus compounds that we have taken into the clinic, we have studied in thorough QT studies or phase 1 QT work. And so what we can try to do with that is to look at, okay, what was the hERG IC50 with those compounds? What was the Cmax that was reached? And then did they cause QT prolongation or not in the clinic? And we normally give the threshold of about 10 milliseconds here. And that's normally the level of concern in the clinic. And so, what we've done now with that is to use statistical work such as Bayesian inference to try to understand how these have how this will translate into the clinic. So you can essentially use this historical data, and you can then make forward predictions for your new compound that hasn't been into the clinic yet. So, for any compound you can test in your hERG inhibition assay, and you can get a kind of concentration response relationship and derive an IC50. And then you have to make an estimate of what you think your Cmax will be in the clinic. And sometimes it can be a range because we can't always be certain before we go into the clinic. And then we can give for a particular Cmax, we can give a probability of QT increase. So if your Cmax is on the lower end of your inhibition curve, then you will get some probability of QT increase. But if your Cmax is higher, then you're going to get a much higher probability of QT increase. And so, we don't know huge amounts about this compound, but we just know what's gone before, and that's what we're using to kind of make predictions. Okay, and then so these are some examples of the types of work that we've done in our group and with other PhD students. So these are examples of how to do kind of translation for different compounds. So and establish that quantitative understanding between preclinical species and humans. So what I call the top-down method is where you're kind of using those PK/PD approaches. So you'll have a PK/PD model in your preclinical species and in human, and then where you have those few compounds where you have both, you can actually just plot for a given concentration what the effect would be in terms of a millisecond change in kind of ion channel changes and ECG effects. So here's an example where we've actually done this between guinea pig and human for changing QRS interval. And what you can see here is that around a 5% change in guinea pig equates to around a 10% change in QRS in human. And this is really, really good stuff to know, because even when you haven't got the guinea pig and the human for a compound, you've got this historical knowledge, so you can make some kind of prediction, and that's all we want to do, is make a prediction of what we think is going to happen in the clinic. And then this middle out approach, this is where we'll take the in vitro inhibition data, the concentration response there. We'll take the concentration response in human, the clinical one, and then we'll establish a set of system parameters that can provide you with the translation. So it seems similar to this, but it's not, because you're actually linking it back to a level of inhibition in that in vitro assay. So we established this for one particular compound here, and so for the human NAV 1.5, 5 to 7% of inhibition equated to around 10% inhibition of QRS. And so what we were able to do was, this allows us to then, with a new compound, and here we just use tool compound flecainide, you can model the clinical effect with flecainide, you can look at what the in vitro concentration response relationship was, and then you can see how closely that matches with our previous understanding with this 1305 compound. And you can see that it's relatively good predictions here. So you can see here that we're starting to build up kind of quantitative understanding on this. Let me go forward. So, you know, many of you will be familiar with the kind of multi-ion channel inhibition models that exist at a cellular level. And these are, you know, fantastic models, but the challenge for us is really how we use this in drug development. So, you know, these are very complex. How do we get out what we need without making this overly complicated for many of the scientists involved? So as modelers, sometimes we're involved with setting up kind of user interfaces that make these things kind of user friendly. Other times it's, you know, our judgment is whether we should use these types of models or not. I mean, to have this, you know, this goes one step further forward than what I've shown previously around, you know, just single ion channels and trying to translate that. But you know, you have to be sure that that's needed in a particular situation. So we don't just use these as a routine. And I think now with the kind of HESI initiatives to try to make these more used within industry, we're trying to now think about how we want to use this. Now, we normally have the information needed for these types of cellular models at a very early stage in drug development. So once we've synthesized the compound, we're pretty much testing it straight away in the molecular assays. And then compounds that have a good enough profile, and that means, you know, quite broadly, you know, i.e. they have good potency, primary pharmacology potency as well. These will then go forward into phenotypic assays. Eventually, the best compounds will be filtered down into in vivo models, and then you'll get a candidate drug that may or may not make it into the clinic. Now, if we're getting the in vitro inhibition assay data here, you would imagine that we might want to straight away run that kind of cellular assay. But often, until we reach this in vivo model part here, that's when we actually have a more confident human predicted Cmax. And that's normally what we need in order to make reasonable predictions about what's going to happen in the clinic. So often we're trying to balance this. So we have the data early, but we don't have confidence in where we're going to be in the clinic until quite a late stage. And then, of course, you know, sometimes we can't always attribute effects to particular molecular targets and you know, basically non-standard mechanisms, things that aren't kind of relatively screened for. And then these just don't get captured in this kind of situation where you're doing that early front loading of screening. So we just have to make that balance. I'm happy to take any questions at this stage, or shall I continue?
Any questions from the audience? As I said, the point here is to make some interactions. Raise your hand or directly unmute your microphone.
Hello?
Yes.
Sorry, I can't see if anyone's got their hand up. So I'm in presentation mode.
Yes, I'm checking. Nobody is raising. Yes, gotcha. No, yes. No, there was a hand raised and dropped.
They can think about their question as we go through.
Keep thinking your question, guys.
Yeah. Okay, I'll continue, and just let me know. Please interrupt if anything's not clear. Okay, so then now I'm going to talk about hypertension risk caused by VEGFR2 inhibition. So we had a project and we knew that VEGFR2 inhibition was going to be a selectivity issue. And we also had a kind of target from senior leadership within the company to try to make compounds that avoided this hypertension risk altogether. You know, often that's very, very difficult to achieve, but you know, I can show you how we fared with that as we go through this next example. So we took two different approaches here. I looked at existing or established my own models of blood pressure change after treatment with VEGFR2 inhibitors. And we worked on data that included patient data and animal data. And then secondly, we tried to establish an understanding of the incidence of hypertension in the clinic. And I don't know how familiar you are with trying to link blood pressure to hypertension, but it's not always easy. The way that hypertension is measured in the clinic is as an adverse event grade. So you have kind of very broad categories of hypertension. And then when the patient data is reported, it's reported as being a grade 1 or a grade 4, and you know, grade 4 being more severe. But that doesn't really help you in trying to establish a kind of quantitative link between blood pressure change and hypertension. But we knew that if we wanted to get a good compound, we needed to minimize blood pressure increase. So to avoid any hypertension risk. Now, you can't avoid some hypertension risk because often the patients that you're in may be older, and other factors can play a part, such as weight, family history, the diet they're on, etc. But we kind of put a target to ourselves that we wanted to be less than 1 millimeter of mercury of blood pressure change at efficacious doses in man. So we started out by screening compounds in a rat telemetry, and this is a plot of the concentrations over time, and this just gives you an idea of the kind of study design that we ran. So first of all, we ran a single high dose of the compound, and this is an AZ compound, so I can't tell you any more about it. And then after a period of time, the animals were kept on, they weren't sacrificed. Then we ran a low dose to see what happened there. And then we ran a kind of intermediate dose, and we ran it as 3 repeated doses. And then we were able to make this kind of PK model. It's just an oral 1 compartment PK model. This PK is non-dose proportional, but that kind of doesn't matter for the purpose of this presentation. But just to let you know that in kind of toxicology studies, often we see kind of weird and wonderful PK. So this is the data where we've measured systolic blood pressure. And what you can see is before each dose of compound, the day before, we've actually run a vehicle control. So prior to that, the blood pressure is kind of quite flat and conserved. But what we see is when we give the vehicle dose, we see a peak in blood pressure and then a return back to lower levels. And then what we see is then the drug effect on top of that in the subsequent days. And so the open circles is actually the observed data over time. And the grey is the individual model fit, and the black is the population fit. And so for this, I've used non-linear mixed effects modelling. And so we the vehicle effect. So we include a description of what happens during the vehicle day, and we just assume that the blood pressure goes up because it's some sort of handling effect. So because we're intervening with the animals, that their blood pressure is increasing as a result. And then for the drug effect, we use an effect compartment model and a linear drug effect. So this is really quite simple PK/PD modelling here. And we account for between subject variability on the handling effect and on the effect compartment parameter. And then this is the second compound now. So this is Regorafenib tool compound that we're studying that was already in the clinic. So here we do a slightly different study design. We do the vehicle control and then 3 subsequent doses. on the left is 8 mg per kg, and on the right is 16 mg per kg. And you can see a higher effect at the higher dose. Now, what you can see here is that there was no handling effect needed. So during that control day, the data is pretty much flat, and we don't need to account for that. And then, but we do need to account for the delay between the pharmacokinetics and the drug effect appearing, and then also between subject variability on various parameters. And then the third example is then what we could find in the literature. So for Sunitinib, I was able to find rat data at vehicle control 5 and 50 mg per kg for 3 days. And I had to model this using kind of a circadian rhythm function, because you can see there's like a daily variation in this data. And then at the highest dose, you can see that there's kind of an increase in the blood pressure. And this data all came from the rat, but was lucky enough to, if you can digitize the data, then you can kind of try to model it. And then also in the literature was kind of lots of examples of clinical blood pressure changes. And again, they've used a different model ones that we've used before. So they've used an indirect response model, where you've got inhibition on K out, if anyone knows about indirect response models, and then a linear drug relationship. So it's actually really hard then to start comparing across all of these different compounds, because they've all needed slightly different modelling approaches in order to capture the effects of the compound. So what we try to do is to think about how can we take away all the kind of drug-specific needs and make sure that we're comparing them all on a like-for-like basis. And to do that, we simulate all the studies to steady state. And so this is the kind of outcome of that. So you can see that on the x-axis, we've got C average unbound, which essentially is AUC, so the kind of daily measure of the total exposure. And we've normalized that for potency against VEGFR2 here in this plot. And then we've plotted it against blood pressure elevation. And we've pulled together human data, rat data, internal data, external data, everything's together on this plot. We looked at various different VEGFR2 assays. Eventually we settled on this PIC assay. So it's a cell-based functional assay that we found that it kind of, if you do these plots with different VEGFR2 assays, this gave us the tightest data across compounds. And in terms of the PK driver, we could have used Cmax as well, or Cmin, but AUC, I think, just gave us the best overall measure of exposure. Sometimes these effects can take some days to build up, and so reflects that a little bit more. And using C average just allows us to keep in the same scale as the IC50. So this helps when you're trying to communicate this to kind of chemists and other people on the project team. And what I will say is that rat and human looked reasonably sensitive against one another. Okay, so this is the same plot now on the left-hand side. And I've put on the 1 millimeter of mercury kind of threshold that we set ourselves at the start. And you can see that, you know, compounds seem to hit that at around 0.1 on this scale. Now, then I said that we were going to have 2 pieces of evidence that we were going to use to make our decision on how to avoid hypertension risk. The other one was hypertension incidence. So here, some of my colleagues pulled together all the clinical data that they could find on tyrosine kinase inhibitors that had kind of VEGF2 risk. And so again, we use the same kind of scale on the x-axis, but on the y-axis now it's percent into incidence of all-grade hypertension. And so you can see here that at 0.1 as well, luckily, this is where the hypertension risk starts to increase. Now you can see that the data is really variable. You can have, even for within a compound, a similar kind of exposure, you could have like no hypertension, and then you could have like 60% hypertension. So, you know, this isn't ideal data, but this is real data, and it really depends on kind of patient baseline and other factors that you can't always kind of remove from this kind of data. Okay, so then how do we use this in a real drug project? So I'm going to kind of give you an example of our potent and selective KIT PDGFR alpha inhibitor AZD3229. So
Teresa, if you're going to stick to 3-5 minutes, that would be great.
Yeah, okay, I'm nearly there. So we have, it's very potent against KIT and PDGFR alpha, but it has really good selectivity to VEGFR2. So we're kind of almost avoiding this risk from the outset. And compared to clinical competitors, it's a much improved profile. And it's good selectivity wise across a number of different targets as well. So you can see these like kinome panels here as well. So, you know, if you can see a lot of blue, then it's not that selective. But 3229 has a better profile than our competitors. And you can see here the rat telemetry data, again, a vehicle day followed by 2 drug dosing days, and a slight increase in blood pressure, modelable, luckily, and then we're able to, you know, produce that kind of concentration response relationship that we're looking for here. So this enabled us to say that at the predicted human efficacious exposure, which is this dotted line here, that we should be kind of at this low end of the blood pressure change. So we're just hitting that kind of 1 millimeter of mercury threshold. So that gave us kind of, you know, confidence to take this forward into clinical development. And unfortunately, I can't tell you any more about that compound because we've since out-licensed it. But it was a really good learning experience. And I think it would have a good profile in terms of hypertension risk. But, you know, I think what we learned from this was really the kind of modelling both blood pressure and hypertension gave us confidence, and just the fact that they agreed well meant that we had a good profile. We could understand that the rat telemetry model was sensitive for testing. The dog model was not. I haven't shown any of that data, but dog is our kind of standard non-rodent telemetry, and we couldn't use that in this example. It just wasn't sensitive enough. And then we're able to help projects drive chemistry. So this kind of learning, you know, test early in your in vitro assay. Once you understand what your human Cmax is, then you can make a prediction for what you're going to see in the clinic. That's time again after this. You're able to estimate your therapeutic index before you go into man, and I think that's really important. Okay, I'll stop there. And if you've got any questions, just let me know.
Beautiful. Thank you very much, Teresa. We have a few minutes for questions. We have gone through a very general view of the field to a specific example. So don't feel shy to make any question around the big use or the big picture of the use of models and any of those examples. Audience, engage. Beautiful. Francesca.
Hello, thank you very much for this very nice talk. I just wanted to ask you, how can you take into account inter-subject variability in your safety assessment? For example, if you want to consider a patient who would have some underlying disease condition, and how may drugs be safe for them or not?
Yeah, so it's often hard to predict from toxicology studies to specific patients where they have risks, because we're typically using healthy animals in our toxicology studies, so we don't always capture that. What we try to do is kind of like do a literature-based review of what we see in those patients, and then try to understand if the therapeutic index is reduced or increased maybe as well for those patients. So yeah, it is a real challenge. I don't have any answers in terms of what we can do preclinically, but we try to look at whether the risk is worse in the and try to factor that in.
Thank you.
Thank you very much. Audience, more questions? Yes, Kasia, if I'm pronouncing that right, please engage.
Yes, thank you. Thank you for a very nice presentation. So I have a specific question about the blood pressure change. Yeah. So you set this threshold of 1 millimeter of mercury. How can you set such a specific threshold? Because I can imagine that the blood pressure can vary a lot between different measurements, and also between, a cell line or a human or a rat, as an example. So how do you decide?
So, you know, we could have said like 0 millimeters of mercury as well, but then if you look at a lot of the curves, they never quite hit 0. So we tried to take, if I show you this plot, you know, when you have these concentration response relationships, you never quite reach 0. So it would have been impossible to set a threshold of 0. So we took kind of 1 millimeter of mercury. Now, yeah, I think in practice, it's hard to say whether something has 1 millimeter of mercury change or not, because it's such a small change compared to like these between animal variability, the between subject variability. But it, you know, you have to have something to aim for. So this is what we chose.
Sure. Thank you.